Yeah.
The thin patella cut. Obviously, the best is to avoid. Mike gave a good talk on how to avoid it. Remember, what are the 5 hardest cuts in a total knee arthroplasty? The patella. You can always cut a little bit more. You can't always take away, put it back. But what do you do if it occurs? You can leave it alone, onlay, Biconcave, Gull wing, bone graft, Tantalum Patella, and there's some new options. So one is just keep the current patella, just accept the thin patella, okay? Um, um, Next is you can go to onlay design, all right? Here you can get with a little bit of thick, less thick remnant. It actually works for 10 to 12 millimeters, and it gives you some extra flexibility. And this is what a biconcave design works. We do have it at our hospital. This is more important for revisions. You usually don't plan to do a thin patella cut, but if you are doing a revision and you think you may have to revise the patella, I would have this available. You cement it in a bony shell, and some studies you can actually go to 5 to 10 millimeters if you need it. And here's the results. In this series, they had 6.5 millimeters of thickness. Hopefully, when you're doing your primary knees, you're not cutting down to 6 millimeters. Usually, you want about 14 or 15 if you're reproducing the anatomy, and you drop down to 11 or 12. This may be an option. And here's another study as well. Good results noted. Resection arthroplasty. Mark Pignano did this when he was a fellow with us a long time ago. The problem is many of them still have pain, and it tends to deteriorate with time. If you look at some of Jay Parvizi's work, not revising or placing a cut patella makes them significantly weak, and many of them don't return to their normal patellofemoral activities. And here's his study. It increased with time, and actually 6 patients later had a patelectomy. Now, the Gull wing osteotomy, this is kind of a sexy topic, and Kelly Vince helped make it popular. And Mark Hartspan has done several of these and written on their results. So if you look at Mark Hartspan results, deficient patella at revision, and what they do is they go ahead and cut the patella vertically. So it's kind of a leap of faith. We're just doing a vertical cut in the patella and allow it to wing forward or wing out. So that's what it looks like when it's in place, and eventually it heals, and that tends to give you how to handle the thin patella. This is a tantalum patella. This is made by Zimmer, and it's a tantalum shell that goes into the bony bed. Once again, if you're doing a primary knee, you probably don't have this available. You sew it into place, and here's an example. So there's your bony bed. You sew it into place, and then you cement the patella on. And here's another case example. The problem with this, if you are going to use one, you need bone for ingrowth. All right. If you have less than 50% coverage, you have less ingrowth, and it may not work. So just remember that if you want to go this route. I once tried to sew this. I thought I was going to be a hero. Somebody did. She had a patelectomy, and I just put this in soft tissue, and it failed miserably, but gave me a great X-ray. That's what it looks like when it heals. This bone grafting or ravioli procedure, Arlen Hansen from Mayo Clinic made it popular. It's really a grafting. They describe taking a periosteum. Since Sam, the sports guy, is with us, I like a graft jacket, and I just take a graft jacket and sew it around the patella. You go circumferentially and make a little pocket, just like a ravioli, and you stuff it in place with cancellous bone graft. Now, the key here is if you're going to do it, overstuff it. It tends to compress with time. So you want to circumferentially, you leave an opening, you pack the bone graft, then pack a little extra, and that's what it looks like. Here's 55 months later. And he's written this several times. Arlen's even gone back and put patellas back in. Here's a patient that I've done, followed for 15 years now. That's what she looked like in 2005. And you can see it fragmented a little bit, but she's been asymptomatic and kind of condenses with time, and just, there it is at 2011. So the key is you fix at the quadrants, and I like to use a graft jacket to help hold it in place. There are some new techniques out there for if you have a thin patella or you want to augment the patella. Here's a transcortical wiring technique of an onlay prosthesis. This was done with 30 consecutive patients. I've never done this technique. I've done all the others that I mentioned. And you're basically using wires to help fixate this. And here you put the wires through the patella, you pass it through the bone, then you fixate it on the dorsum of the patella. And here it is in place again. I don't like to have wires around the patella. Somehow I think those are going to break away, just like they do with the ORI for the patella, but certainly this is described in the literature. So when you have a thin patella and you didn't avoid it, so what do? I think you should resurface if possible. I don't like the resection arthroplasty. I like the onlay, and I will go up to 10 to 12 millimeters of bone. It's really only one. Scott Rubin has one study that says 12 is the limit. I think all of us have cheated, and usually it's not, if it's 10, it's only in one quadrant. Remember Mike Ash talked about measuring the 4 quadrants. Sometimes you're lifting your hand up and the superior aspect is thinner than the posterior. I think the concave is a good result, and it's a good bailout. If you have deficient bone, because now this is a different beast, do the Gull wing osteotomy, bone grafting technique, or the Tantalum Patella. And here's a nice classification of what to do if you have bone stock or you don't have good bone stock by Bose and Reese. So I think the bottom line here is the thin patella is something that you did. It's a complication, so the best is to avoid. The way that I approach it is I measure the patella, and I'm not concerned about that preoperative versus postoperative thickness. That doesn't make much sense to me because it's the patellofemoral joint, and how can you measure the patella? If there's a lot of wear, you don't want to reproduce a worn out patella height, but it does give you an idea of how much you have to cut off. So while I'm not big on measuring the patella to reproduce it, I use anatomic landmarks. I use a freehand technique. And by doing that, by measuring beforehand, if it's only 15 or 16, I know I want to do a skim cut. I know how much I want to take with an initial osteotomy. If it measures 24, then I know I want to add up 15. Well, then I can sit there and go ahead and plan my osteotomy based on the preoperative resection. All right. So the best thing is to avoid, take less bone, and you can always take a little more if it's still too thick. Thank you.